Thank you for joining us today for our Parkinson's Disease in the News, a fireside chat. Today, we welcome Dr. Salina Schaefer, a movement disorder neurologist here at the Muhammad Ali Parkinson Center and an assistant professor in the Department of Neurology at Barrow Neurological Institute. Thank you for joining us, Dr. Schaefer.
I'm going to be continuing the idea of the fireside chat. So as you can tell, I'm rather informal. Whenever you have questions, just kind of throw them into the chat. I'll be happy to answer. But I did want to cover, there have been several things in the news in the last couple of weeks over Parkinson's. So I would like to cover several different topics. First and foremost will be the announcement this week that Brett Favre has Parkinson's. And that always, when a sports player or someone famous announces, it always incites the question of what actually is Parkinson's and what causes Parkinson's. So I would like to go over concussion, TBI, and risk of Parkinson's. There have been a couple papers released this week regarding GI links, gastroenterology links, and Parkinson's. And then talk about a couple of different things, such as diet and Parkinson's, specifically seaweed. And then there is a new medication coming out this month called Crexont by Amneal. So I'll be covering that at the end. Forgive me, I am quite fidgety. So as I move around, I'm sorry to make anybody dizzy. I apologize. So without any further ado, let's get started. So again, but Brett Favre, who is a famous quarterback, he announced this week that he has Parkinson's. And that has been the ongoing theme of my clinic this week. Everyone's coming in asking, was it the football that caused it? What actually caused Parkinson's? And in answer to that question, we actually don't know. To take a long step back, Parkinson's disease was described over 200 years ago by James Parkinson's. He called it the shaking palsy. Now it has been described further back, but the seminal paper was written over 200 years ago. James Parkinson's, he based it off of 6 people, and he saw similar symptoms in those 6 people. 3 of them he examined in clinic, 3 of them he saw out on the street. He wrote a paper, published that paper. Many years later, people started saying, we're starting to see the same thing. And so many years later, it was called Parkinson's disease. So that's 200 years ago. 60 years ago, approximately, is when they figured out it was a dopamine-based problem. And we started giving people with these symptoms dopamine. And dopamine is a chemical that our brain makes. When you don't make enough, it can cause, or you don't process it appropriately, it can cause funny movement disorders like tremors, slowness, sometimes decreased fine motor skills. So we started giving people dopamine about 60 years ago. For those of you that have Parkinson's, carbidopa-levodopa. Levodopa is the active form of the drug. That is what is metabolized in your brain to dopamine. And we started giving that to people and started to figure out there are different disorders. So there's Parkinson's disease, and there's things that look like Parkinson's but are not, and we term those the Parkinsonisms. So to concussion, okay, what causes this issue? We don't know. There are many theories. There has been nothing that has been proven. Going through the literature, it's a little frustrating, and I'll explain that today, that a lot of the papers suggest things like concussion, traumatic brain injury, infection, things like that can cause Parkinson's and lead to this inability to produce dopamine and process it appropriately. And then other papers suggest, no, that's not true. According to the Parkinson's Foundation, just one single concussion in your lifetime leads to a greater than 50% chance of developing Parkinson's later on in your life. Again, we don't quite understand it, and the literature is varied to make that a point. There was a paper written it was published in JAMA back in 2013, and it suggested there was no correlation between mild traumatic brain injury and Parkinson's. Just 3 years later, there was a paper written by the VA who actually said that just as a mild TBI and seen in the veterans, mild traumatic brain injury as seen in the veterans, had a greater than 50% chance of causing Parkinson's. So again, I think it's a lot more complicated, and all the literature suggests that it is a lot more complicated than what we think. There is an idea that, number one, these are different disorders. It's not going to just be Parkinson's disease or these Parkinsonisms, it's going to be different disorders. Number two, is it related to traumatic brain injury? Some are going to say yes, some are going to say no. Not everyone that has traumatic brain injury developed Parkinson's, and not everyone that has Parkinson's has had traumatic brain injury. So again, there's a correlation, not a causation. When you think about it though, it does make sense that if you have some sort of acceleration, deceleration injury to the brain, or some sort of injury to the brain, you have your brain tissue, and the brain tissue gets damaged so that it cannot function the way that it should. Going down that line, a lot of function of the cells of the brain, they are trying to wash out toxins, they're trying to wash out things that enter our brain that shouldn't be there. And so if they can't fulfill their function of washing out those toxins accumulate in our brain and basically allow things to show up that shouldn't be there, such as Parkinson's. There are several other things seen. We know for a fact traumatic brain injury causes things like dementia, things like CTE, so encephalopathies. We know that that happens. And so the question here becomes, why do some people get Parkinson's? Why do some people get dementia? Why do some people get a combination thereof? And again, the idea in all the literature, the idea is that there are different, when cells can't get rid of the toxins, those toxins develop different proteins and deposit those abnormal proteins throughout the brain and the body. And different people are exposed to different toxins, which again, this is all theory, but this is where some people believe that you can develop, again, dementia after having traumatic brain injury. Some people develop Parkinson's, some people develop different disorders. There was a paper that was published recently that talked about Lewy body dementia, which is a Parkinsonism and concussion. And there's a higher risk of Lewy body dementia with concussion. Again, all theory, all question, but it's an interesting pathway that needs further study. Along that route is also, so to wrap up very quickly, did football cause Brett Favre's Parkinson's? We don't know. Did the traumatic brain injury over his 20-year career lead to Parkinson's? It's a strong idea that it could. Is there a guarantee? No. But could it have? Yes. Now, some of my patients that have never played a sport in their life, has never had traumatic brain injury, have Parkinson's? Yes. So is it definitely the cause? No. Could it have led to his Parkinson's? Yes. So I hope that kind of sums up traumatic brain injury, football, boxing, Muhammad Ali Center at boxing. The idea behind neurologists, we always say, please protect your brain. Time is brain, neurons equals cognition and function. So please, we always suggest highly protect those neurons. So I hope that wraps that piece up. Moving quickly over to GI. There is, again, going back to, we don't know what causes Parkinson's, and there is a theory that they are going to be different disorders. For the gastrointestinal tract, there has been research over many years over this idea that Parkinson's could start in your gut. And it's these misfolded proteins and these toxins start in the GI system, travel up the vagus nerve, go to the brain, and then deposit also those misfolded proteins in the brain. The idea behind this is that a lot of people with Parkinson's, they have GI issues, constipation being one of the heralding signs of Parkinson's. And they have done many animal studies that suggest, again, it starts in the gut, travels up the nerve, goes to the brain. And in a lot of these studies, you can actually sever the vagus nerve. The vagus nerve is a nerve that goes from the brain down to the GI system. In several animal studies, they have severed the vagus nerve, and it stops the progression of these misfolded proteins. Now, they have done that study on humans, and it didn't stop the progression. So for a while there, this GI theory kind of went to the wayside. Lately, there was a paper that was actually just recently published that has it's interesting theory, that again, going to these subsets of Parkinson's. Could there be indeed a subset of people that have Parkinson's that it actually starts in the gut? So this is the gut first theory. And it's a subset of people. Could it have started in the gut, travels up the vagus nerve and goes to the brain? And then that other subset of people where it starts in the brain and then travels through the body, through the nervous system. So in dealing with that, and dealing with the gut first theory, also there have been a lot of research into a bacteria called H. pylori. H. pylori is famous for causing ulcers. And interestingly, a lot of the research suggests that people that have Parkinson's have a much higher risk of having H. pylori. And so again, this leads more and more research towards this gut first theory in this subset population. And what this paper, this is the upper GI mucosal damage and subsequent risk of Parkinson's disease. This was published in JAMA earlier this year. This is the paper that I'm alluding to. And what was very interesting that these authors posited was that, okay, people with Parkinson's have a much higher risk of H. pylori infection. But H. pylori is found in many people and they don't have symptoms. So what is that connection? And so the idea that they came up with was this mucosal damage. People that have mucosal damage in their research, people who have mucosal damage and H. pylori, they have a much higher risk of Parkinson's. But people with just H. pylori and H. pylori with no mucosal damage, they don't have a much higher risk of Parkinson's. In fact, there seemed in their paper there was no correlation between the two. So again, no mucosal damage plus H. pylori equals no correlation to Parkinson's. An interesting idea that they came up with as well is it the mucosal damage leading to the Parkinson's, or is it the Parkinson's leading to the mucosal damage? And the reason why they came up with this concept is that dopamine, again, the chemical that our brain makes that allows for movement, dopamine is actually protective for the gut. And so if you're not making enough dopamine, does that mean that your gut is now more susceptible to mucosal damage, ulcers, things like that? And that is an interesting theory that has been yet to be studied. So that, again, this is a great paper that I highly recommend you guys read. And it kind of walks you through this gut first theory. And it's definitely not the cause of everyone's Parkinson's, but could it be the cause of some people's Parkinson's? It could. Now, or could the Parkinson's be leading to this? Yes. So again, I told you the first part of this talk is going to be quite frustrating because this is all up in the air. It's all major question. But these are good steps forward to our research. I will tell you personally, my idea is that it starts that you're born with it. It starts in your individual genetic code. So there's an individual genetic mutation, not that you pass it down through families. Yes, there are genetic versions as well that you do pass down through families. But my personal theory is that you are born with it, and then so many environmental factors hit your genetic code, meaning concussion like Brett Favre, or TBI, ulcers, mucosal damage, the idea behind bad diet. I don't tend to lean towards just the gut first theory, simply because Parkinson's is found at any age in any population all throughout the world, and we're not all exposed to the same gut microbiome. But again, this paper was eye-opening to me, in that definitely could it, in the subset population, start in the gut? Yes. Moving on really quick, sorry, I know I'm limited in time, but that takes me to diet and Parkinson's. The Movement Disorder Society will say Mediterranean diet gives the best, it's the best diet for Parkinson's. And it's mainly because it's a healthy, well-balanced diet. And that's, if you are one of my patients, you'll always hear me talk about healthy, well-balanced. In your life, you want to be healthy, well-balanced at diet, exercise, stress levels, things like that. And so for diet in particular, the Mediterranean diet is a great template for a healthy diet in your life and in the world of Parkinson's. There is this, over the years, sometimes it comes out about seaweed or what diets can we do to help with Parkinson's. And lately I have been seeing a lot of articles pop up about seaweed and Parkinson's. And again, the seaweed theory goes back to this idea that, again, it's an inflammatory disorder. Parkinson's, it can be an inflammatory disorder. So basically you injure those nerves start to cause inflammation in the brain and the body. And then the rest of the nervous system comes in and they try to wash out that inflammation, and it actually causes more inflammation, and it kind of just propagates the whole thing. And that leads to the neuronal cell death and leads to the Parkinson's. So the idea behind seaweed is it's actually highly nutritious. It has a lot of anti-inflammatory properties. And interestingly, there are different versions of seaweed which have different vitamins, different minerals, and different anti-inflammatory properties. So again, it comes down to A, taste, B, more research in animals. If you give them these, there's a lot of brown seaweed, and then a lot of the research is pointing to red, green, and brown seaweed. But brown seaweed in particular, tends to have more anti-inflammatory properties. And it seems in animals to actually prevent this propagation of inflammation in the brain. The studies that I have read on this, they are limited in that they're using a specific way to cause the Parkinson's in animals, which is a much more inflammatory way than what we usually see in people. And so this is where they're giving them a specific chemical that's leading to inflammation and blocking the inflammation with the seaweed properties. So that is a limitation in the studies of seaweed. The other limitation in the studies that have been published most recently is, again, they've been done in animals, nothing in humans. So I think time is what's going to tell us regarding seaweed. My recommendation regarding that is, as long as you're not an allergic person and you like the taste, seaweed actually has a lot of good, it's packed full of nutrients, has a lot of B vitamins. It's filled with A, D, K vitamins as well. So if you happen to like the taste, go for it. If you don't, my recommendation is more healthy, well balanced. So Mediterranean diet, or follow the template. If you don't like Mediterranean food, don't eat Mediterranean food, but just follow the diet. Again, healthy, well balanced. I do want to run briefly, and I want to spend most of my time on the new medications. So again, what causes Parkinson's? We're not quite sure. We have a lot of theories. What can we do to prevent Parkinson's? Healthy, well-balanced lifestyle. That is the best idea. How do we treat Parkinson's? As I said before, it is an oversimplification, but Parkinson's is a disorder of decreased dopamine. Our brains doesn't make enough dopamine, and it doesn't process it appropriately. When we figured this piece out, we made that medication carbidopa-levodopa. Carbidopa-levodopa levodopa is metabolized into the brain, or in the brain, to dopamine. So L-dopa, levodopa, metabolized to dopamine. Carbidopa is an added drug to allow more dopamine to get to the brain, and it basically blocks the absorption of levodopa in the gut, allows more of it to get to the brain. Since the invention of carbidopa-levodopa 60 years ago, we have many different versions of it. And what it does is the immediate release, the age-old version, the immediate release, you take the pill in about 20 minutes, it starts to metabolize. It has to get down to an area in your gut, starts to metabolize, gives you a big peak of dopamine, and drops you back down within about 3.5 to 4 hours. Most people like that peak. They like to be up there. And it gives them the ability to function. It seems to be the best time that it gives you the best motor ability, gives you the best internal feeling as well. So since the invention of that drug 60 years ago, we've tried to match that peak and have it last all day long, and we've never been able to do it. The controlled release carbidopa-levodopa, what some people term extended release, it's a pill, not a capsule. That was invented about 25 years ago. And that gives a little tiny steady state of dopamine for about 5 to 6 hours, never gives a peak. So most people tend not to like that drug during the day. The people that we use that for during the day are people that can't tolerate that peak. That peak is where you feel your best, but also all the side effects of levodopa can kick in. So most people don't like that drug during the day. Some people use it at night to make your mornings a little bit better. So again, it lasts 5 to 6 hours. It just makes your night a little easier, makes the mornings a little easier. Rytary came out in about 2015. Amneal makes Rytary. And they thought that they had it with Rytary. Rytary is an extended release. It's called extended release carbidopa-levodopa in a capsule. And what that is part controlled release and extended release. Part controlled release and immediate release combined into a capsule. And what it does, what they hope that it would do is shoot that peak all the way up and then kind of allow that peak to settle into your system and let it be that extended release pill that we're all looking for. And it doesn't do what we thought it would do. While Rytary is a very good drug, Amneal went back to the drawing board to figure out how can we get that first initial peak that everyone likes, or most people like, and then have the drug last a long time. And they came up with a brilliant idea, and that since the invention of carbidopa-levodopa, again, remember it's 2 drugs in one, we've always had them peak at the same time. So the peak of carbidopa and the peak of levodopa always have happened at the same time. And Amneal had a brilliant idea, and they said, well, if carbidopa is the vehicle for levodopa to get to the brain, then you want that peak of carbidopa to be up first. If the peak of carbidopa is up first, then it allows more levodopa to get on. I look at it like a car. So if your car is fully ready to go, and then you can get everything piled into the car, you can get more of it to the brain. And they did it. That is the coolest piece. So they allow carbidopa to peak first, then they allow levodopa to peak second. And so they have more levodopa getting to the brain, and it's much more efficient. The other thing that they came up with was what they call, it's kind of like this sticky piece to it. And I actually have a picture of it. Let me show you, or it's a little cartoon. So I'll share my screen. What they term it is a mucal adhesive polymer. And so I'm going to show you, this is kind of a cartoon of the picture. And again, this new drug, it's called Crexont. I don't know why they called it that, to be honest. But they have, going back really quick, they have the immediate release carbidopa-levodopa, and they have their extended release. Now, the new extended release, it has this sticky polymer. And basically what that allows it to do is stick around in your gut a little bit more. And then it's a real sustained release. So instead of taking the pill, having the pill dissolve in your intestines and everything gets released at the same time, which is what Rytary did. Crexont, what it's doing is, again, you have that immediate release that shoots you up, and that gets absorbed first. Then you have the sticky polymer that makes it stick around in your gut a little bit longer. And then it slowly absorbs down into your gut. And this is what's going to allow the drug to stick around a lot longer. Going down, this is directly from the company's website. So if you guys want to do a little bit more study into this, this is what is actually on Amneal's website regarding Crexont. So if you go here, this initial peak here, this gray one, this is immediate release carbidopa-levodopa, and this is your amount of levodopa in your blood in hours. The second peak here, this is Rytary, so you can kind of see it doesn't really give that first peak, it kind of just peters out like this. And then Crexont, it gives a nice big peak up, and it's lasting about, it's in the study, it's lasting about 5 to 6 hours. So people that are taking their drugs every 5 to 6 hours are now taking 5 to 6 times a day. And the study can reduce it to 2 to 3 times a day. And you have about an hour to an hour and a half longer on time per dose, of good on time, not just on time, but of good on time. And then the study also showed a lot less off time as well, which correlates. But in the study, I understand it kind of seems intuitive, but in the study, it actually was a beautifully done study where, again, more on time, but good on time and less off time. So Crexont will be out, actually, it's available, it should be available for places that give samples, it's available today. And then it'll be available in the pharmacies as well, starting this month, beginning next month as well. It's not going to be for everyone, so always when I talk to people, remember if you know one person with Parkinson's, you know one person with Parkinson's. And the treatment of Parkinson's is individualized. So there's reasons why we use certain drugs for certain people. Again, I think Crexont will be, it was a beautifully done study with a novel idea that it seems so intuitive when you think about it, but nobody had done it for 60 years. So again, it will be impressive when it comes out, and we'll see how well it works in the general population. This is the newest drug that is coming out, and again, we're all very excited. There are a few other drugs that will be coming out soon. I kind of don't want to address them just yet, as the FDA has not given their full approval. So when the FDA does give their full approval, I think that would be nice to have another fireside chat regarding all the new drugs that have come out. Anyway, that is my talk. If there are questions.
In relation to the Crexont, one of the questions was, will it have the same eating restrictions like IR and ER do? My assumption is that's with the protein in 30 minutes
So
before.
unfortunately, the protein sensitivity issue in Parkinson's, it's anything that passes through the gut. So dopamine and protein compete for the same receptor in the laboratory. So now, once it's in your bloodstream, the issue here is because, again, Crexont is going to be a longer term drug, right? So the idea is, should you take it around protein? That remains to be seen. It does indicate the study, because it is carbidopa levodopa. It comes with the written same restrictions of avoid protein. Now, it's a longer acting drug, so the idea is that, an hour outside of that pill. So if you're taking your pill, your immediate release every 5 to 6, or every 5 times a day, 6 times a day. If you can take this drug 2 or 3 times a day, then you don't have that huge restriction of timing. But in short answer to your question, yes, it will.
Wonderful. Quick question that was asked is just, can you just explain a little bit more about where dopamine is produced in the body?
So dopamine is made
Talk about that.
in the brainstem. It's an area of the brainstem called the substantia nigra. Substantia nigra means black substance. This is actually, forgive me, I'm a little bit of a nerd. And so this is how, going back through the history, this is how they figured out that this is a dopamine-based issue. Forgive the nerdiness and a little bit of the grossness. So through autopsy, the substantia nigra shows up as this little black ring in the brain, in the brainstem. It's like this little black line. And they started to notice that people at autopsy that had Parkinson's didn't have, or they either didn't have that little black line, or that little black line was faded. And so then upon further investigation as to that black line, they figured out that was a dopamine-based issue. Interestingly, or dopamine. And so dopamine is made in the back part of our brain, in the brainstem called the substantia nigra. And then it seems to be metabolized in the mid part of our brain called the basal ganglia. And the basal ganglia is, it's a lot more complicated than what I'm talking about, but it's involved in the motor circuitry of the brain. The brain runs on electricity. And if you think about dopamine kind of like an electric current, it isn't. But if you think about it like a chemical that's creating electric current, that's what it's doing to make the motor circuits run. And so the way I also look at it, it's kind of like oil in the car, or oil in the gears. That's what it's doing. It is involved in, again, this is a big, huge oversimplification. It is involved in the autonomic motor system. It is involved, or the autonomic nervous system, as well. And so that's where you'll see, the other thing is dopamine is involved with all the other chemicals that the brain makes. So serotonin, norepinephrine, melatonin. As dopamine goes down, these other chemicals start to go haywire, which is where you start to see changes in blood pressure, mood, dreams, digestion, everything that you get. So those are a lot of the non-motor symptoms.
Thank you so much. I appreciate it. So thank you again for coming, Dr. Schaefer. Thank you so much for taking time out today to come and do this PD in the news. We greatly appreciate it. It's always questionable when we hear things in the news or we read things. Do we believe it? Is it true? What should we be doing it? Do I need to rush out and eat seaweed? It's not my favorite, but you'll do it. So thank you so much for helping us clarify some of those things. And we appreciate everybody coming today. Have a great afternoon.